Assalamu alaikum. Now the second part of discussion of diabetic history. So after doing the presentation, what may be the differential diagnosis if it's a case of recurrent hyperglycemia, that the causes may be poor compliance, uh, improper diet, carbohydrate mentoring, less exercise, infection, puberty, dawn phenomena, somatic phenomena, and due to hyperthyroidism, celiac disease. And if there is the known case of diabetes presents with recurrent hypoglycemia, in this scenario we have to in differential diagnosis or the cause behind this, we may consider if there is excess insulin increase or excess missed meal, excess exercise, depression, anorexia, Addison disease, hypothyroidism, celiac disease, honeymoon period infection. This may cause the hypoglycemia attack, recurrent hypoglycemia. Okay, and then how will you manage the patient, or first of all, what investigation if it is a diagnosed case of or known case of diabetes. So we will first go through his previous records, and as his presence with hyperglycemia, so blood sugar, blood ketone, um, um, full blood count with ESR, CRP, and urine RE for any albumin present or not, urine culture sensitivity test, and other tests if needed, such as the celiac screening, celiac antibody, thyroid function test, and guard antibody, immunoglobulin level, and thyroid function test. And then what examination, airway, breathing, circulation, vital sign, and anthropometry, skin survey, special attention for the site of insulin injection for any lipodystrophy present or not, and any vitiligo present or not, and neurological examination for neuropathy, and musculoskeletal examination for orthopathy, and para-abdominal examination. And then how will you manage the case? So if the patient is stable, so management should be started from the multidisciplinary team, and then multidisciplinary team member will be pediatric endocrinologist, our consultant, dietitian, specialist nurse, school nurse, social worker, support group, diabetic team. Okay. And then management will start from the counseling, educating the child and the parents, what is the condition, how to take uh, the injection, how to change the site, and giving knowledge what are the signs and symptoms of hypoglycemia, and how to give the carbohydrate mentoring, what is the need of the exercise and the adjustment of the exercise and the carbohydrate intake, and how to check the blood sugar level, how to check the ketone level. All of the advice we will give, and then the advice for the insulin, dietary advice, and regular exercise. That means the lifestyle modification. And one vehicle, there is what are the regimen, insulin regimen. There is two types of regimen. We You can go through the Khidi history taking book, and there is multiple daily injection, three pre-meal short acting and long acting insulin in the evening. Another regimen is the biphasic regimen. Rule is two-third, one-third. Two-third intermediate acting and one-third short acting. And then according to, we can go through the Mark Beatty. The Mark Beatty, in the history, uh, this 2 points is very important, that in the history, whenever we are asking about the medication history, insulin, so do you ever check blood glucose level at night? It's very important because night hypoglycemia may occur in the Somoji effect, so it's essential. And and in Margaret, there is another question was that page number 56, that discussion of different insulin regimen that I have discussed, and whether child should be considered for insulin pump therapy. If discussed pump, so be prepared for indication or eligibility. So eligibility, we can go through the patient info or NHS. Here it is written that if there is multiple daily dosing is not possible, if there is recurrent attack of hypoglycemia despite giving multiple dose of insulin, and the level is not controlled, hemoglobin A1C is persistently high, so this is the indication for insulin pump. And that benefits of insulin pump, and is from patient info. The benefits of insulin pump is that it fears the episode of hypo attack, may help in the diet control, and most of the important benefit, not having to inject a lots of insulin. And what are the risks? So risks is pump failure with a rapid ketosis if not spotted. So chance of ketosis is increased here, and chance of increased weight gain. And then whenever we give the insulin pump, must be safety netting with the parents. If there is fever, nausea, vomiting, any injury, any unexpected weight gain, or increased attack of hypo or hyperglycemia, so they have to contact with the medical professionals. And now the emergency management of hypoglycemia. So when we consider this is hypoglycemia with a patient of diabetes, if the blood glucose level is less than 4 millimole per liter, and so management, if GCS level is less than 8 or more than 8. If more than 8, so first we will offer the solid. If he is not interested to take the solid, so glucogel. But if the child is unconscious and it is at a home or outside the hospital, so glucagon injection. But in case if it is in the hospital, so 2 ml per kg glucose, 10% glucose, and followed by a 10% glucose in 0.9% sodium chloride. And we have to check the level after 10 minutes. And then if not, condition not improved, so we can give injection hydrocortisone. And then how you follow and monitoring diabetes. So in the hidden history book, I'm grateful to the writer. Here it is better written. So at the time of diagnosis, we'll do the hemoglobin A1C, and we'll do it every 3 to 4 months. Thyroid disease at the diagnosis and annually, and celiac disease every 2 to 3 yearly. And in once a year, blood pressure monitoring, microalbuminemia, retinopathy, annually from the age of 12, thyroid disease, review food care, and every 3 to 4 months, height and weight, hemoglobin A1C, and injection site. And now the basic day rules. Suppose gastroenteritis, so encourage regular small sips of sugar containing drink, and monitor blood glucose level less than 2 hourly. If oral intake reduced and blood glucose level is low, in the low range, so it reduce the fast acting insulin during the period of the illness. During the illness, if blood glucose level suppose 10 to 14, so we have to give the usual fast acting insulin. But if it is blood glucose level is more than 14 millimole per liter, so we have to check the ketone. If the ketone level is zero point 0.6 to 1.5 millimole, so we have to give 10% of the total dose in as an addition. And if ketone level is more than 1.5, so we have to add more than we have to add 20% of the total daily dose as additional dose. This about sick day roles, and also uh, emergency management of hypoglycemia. And after in case of emergency management of hypoglycemia, whenever we have to give the glucagon, at the same time we have to call 999. Thank you.